Next, we're going to we have a change in our presenter, but we're going to have Dr. Khai Lam discuss subsidence.
Thank you very much, Brian. Thank you for the Society for inviting me. So I'm sitting in place of Neil Anand, who has been a dutiful father and basically attending the hockey game for his son. So I'm going to talk about fusion subsidence and also adding fixation failure to the talk as well. I think it's important. So these are my disclosures. I think Juan mentioned earlier on, it is a complex interplay of various risk factors. So you have the surgical factors, the surgeon-driven factors, patient factors, which is something that you can't really control, and also the carpentry and implant choice biologics. And all of them have an interplay in terms of whether it causes subsidence, pseudarthrosis, and/or fixation failure. So a number of risk factors, and they all interplay. If you like, the modifiable ones are the surgeon. So you need to know what you're doing. You need to do good carpentry and choose the correct implant. So those are the factors that are modifiable, if you like. And the non-modifiable factors are something that it's outside your control. So this is a slide here looking at, if you like, the 10 different steps. Patient selection, positioning, location, surgical approach, dilation, discectomy, interbody, lateral closure, posterior fixation, and postoperative care. So the non-modifiable is really related to the patient, how old the patient is. That relates to correlates with low bone mineral density. Look at the crest. If the crest is very high, your access to the 4-5 might be difficult, so you might violate the end plate. Does the patient have a global spinal imbalance and/or scoliosis? Because that can actually cause various levels of subsidence, pseudarthrosis, or fixation failure, namely PJK, PJF. Modifiable bits are how you place a retractor, your carpentry, how you put the cage in, and that can have issues in terms of end plate violation, subsidence, and/or non-union. So let me look through various factors here. This is a systematic review of subsidence in lateral surgery. So 14 articles, 1,400 patients, 1,362 patients. So subsidence rates around 10%. So this is a general trend, really, for most articles. But clinical subsidence was actually lower, and therefore the revisions in this study, in this review, was around 2.7%. And over time, there's bone remodeling. So we see over time the disc height decreases, and after 12 months it stabilizes. So this is a remodeling phenomenon that Dr. Malin was referring to earlier on. So the conclusion was subsidence is after lateral is non-negligible, and you should be consenting your patients accordingly. So I allude to Greg's paper, our beloved research director. So he presented this and published this. So he talks about the two types. The surgeon causes the end plate damage, so we call this iatrogenic, and the remodeling phenomenon. And he categorized it into type 1, type 2, type 3 based on the end plate violation. So the type 1 occurred in 14%, so the contralateral end plate violated. The type 2 is most common, where the both end plates are violated in the caudal end plate, and 21% in both end plates. So the clinical subsidence was 3%, but in most part it did not affect the fusion or the clinical outcome, and therefore you should be considering posterior fixation to facilitate the fusion. What about standalone and posterior fixation? Well, this is a nice review of whether you should do standalone and posterior. So 28 studies, 1,462 patients, looking at the standalone versus standalone with fixation. And there's a reoperation rate that was higher if you put a standalone cage in. That was clinically significant. And the incidence of cage movement subsidence is also higher in the standalone. So therefore, a higher reoperation and subsidence rates due to the standalone, and therefore you should consider posterior fixation to supplement your cage. This looks at bone mineral density. I think there's an earlier speaker was talking about bone mineral density, and basically the softer the bone, the more the subsidence, and therefore if you have a low bone mineral density, think about supplementary fixation. So in terms of patient selection, well, practical tips. You look at your crest, all right, make sure it's not a high line. And if you have a really a deep crest, you have angle instruments rather than angle instruments to perform your surgery. There's a tendency here, you will violate the inferior end plate. So a number of studies also alluded to the fact that at L4-5, it's the caudal end plate that gets damaged for this reason. And think about, when you're doing a scoliosis, the angles are very, you have to wand the table, and there's a risk of end plate injury. So think about whether you should be doing these kind of operations when you're starting out doing your laterals. What about osteoporosis? I think this is a big area that a lot of our elderly patients are requiring lateral surgery, scoliosis surgery. So this meta-analysis on osteoporotic patients says that bisphosphonates, this is a use of bisphosphonates, may increase the solid intervertebral fusion and decrease vertebral fractures, pedicle screw loosening, and cage subsidence, contrary to what we think, because these are anti-resorptive, and we were concerned about using bisphosphonates and the impact on fusion. This is a nice systematic review on the use of bisphosphonates and teriparatide. So anti-resorptives and teriparatide being the anabolic biologic. So bisphosphonates associated with decreased odds of cage subsidence and vertebral fractures compared to controls that had spinal fusion. Okay? And then bisphosphonates do not appear to impair the successful spinal fusion compared to controls, although teriparatide use is associated with high fusion rates in bisphosphonates. So this sort of gives the lends clinical credence to the use of teriparatide. So therefore, if you're doing an operation, I would consider doing a DEXA scan on all patients greater than 40, and certainly in adult spinal deformity with a BMD of less than 2. Think about anti-resorptives, bisphosphonates beforehand, for example, and then consider anabolics like teriparatide, most common being Forteo. So in my practice, I use Forteo 3 months beforehand, and then 6 to 12 months post-surgery. The issue is cost. So in the UK, it's £400 per pen, and in the US, it's $3,500 per pen. So it's almost 8 times increase in price. And practical tips, well, when you're localizing, make sure that your AP and lateral images are in a perfect AP. So you see the owl's eyes, you see the end plates in a parallel fashion. And then when you're docking your retractor, make sure that you see the end plates in a parallel fashion shown by the purple lines, okay? So that means you do not violate the end plate when you're doing your carpentry. So likewise the shim, everything in parallel. When you're doing discectomy and trialing, make sure that your cobs are flush in line with the end plate so you do not violate it, and check under fluoroscopy at each time when you're doing a discectomy. I like using the angle curette and the rasp to do my discectomy procedure. And then once you've done that, look inside, see, make sure that the bone is bleeding, because really a good fusion relates to meticulous preparation of your end plates. If it's bleeding, that means you'll get a good fusion. Yeah, look at the bleeding end plates at the end of your procedure. And also when you're trialing, make sure you do not overstuff it. If you're putting a 14 size in there, something isn't right, or you've violated the end plate. I call these the bad boys. I don't like these implants because they're straight, they're not angled, and therefore when I use these rather sharp angled implants, they end up violating the end plate. So I call them the bad boys, okay? I don't like using them. Interbody placement. It makes sense. This is a good slide because the bigger the surface area, the better the loading, and the stress is reduced. This is a nice study from Punjabi looking at the strength of the apophysis, and the strength is really around the ring and more posteriorly. So try to aim across put the cage across the end plates and more posterior. So the purple cage is 18 millimeters, the green is 22, and the white is 26, and we talked about the mismatch and the end plate cover. So it's very important that you cover the end plate with a bigger size cage. So here we have a cage being inserted, covering both end plates and in a good position as well. So check that with the X-ray. A nice study looking at the sizes of the implants, 18 mil, 22 versus 26. And the green, if you go across to to the extra larger 26, you see that flexion, extension, lateral bending, and axial rotation is much improved with a bigger size plate. And we add pedicle fixation, then it gives you more rigidity and less subsidence. And then Roger Hartle looked at the size using 26 mil cage, and he basically eliminated subsidence with the use of a large cage. So it stands to reason from a biomechanical standpoint. And do not overstuff, because if you overstuff, you get an image looking like that on the MRI scan. So a comfortable fit. In most part, I've used 10 mil 10 mil heights. If you want to put a bigger size cage in, think about releasing the ALL before you're putting a hyperlordotic cage in. Otherwise, you get something like this. So I was a little bit over ambitious here. You know, I did release and put a 15 degree, and I rushed it a bit, and I overstuffed it. So, you know, that's not a good looking x-ray. Thankfully, the patient was fine. I had a nasty, if you overstuff it, then you'll get something looking like this. I think one of us, a lot of us may have experienced one of these problems where I've overstuffed it with, I think there were 12s. The patient was osteopenic, and then you see this vertebral fracture. Okay, so the patient got out of bed, and the implant just slipped one side. Severe intractable nerve pain, so I had to go in and revise it, and then use cement augmentable screws. So potential risk factors: low BMD, end plate breach, and oversizing of your cages. What about fusion rates in literature? Well, these studies show that the Lenke fusion rates are around 93 to 97% using various biologic types. And if you look at the meta-analysis, this was alluded earlier on, the fusion rates are around 93 to 97% using various biologics. So here are your bone graft options. Lots to choose from, and I think you need to think about you know, the cost versus the outcome. I use Atrex, which is a nanotechnology porous bone substitute, if you like. And I showed in a study that was presented at SOLAS that the fusion rates were Lenke 1 and 2 at about 12 months, and all titanium cages achieved a grade 1 fusion. So this is a case of the multi-level patient with 18 months of interbody. So the titanium and titanium and Atrex has grown into the end plates in a beautiful fashion. So you need to think about your costs when you're looking at your biologics, and I think if you're using your BMP, there's a tendency for you to be going up this direction, and if you use the Atrex, it's more here down this direction. So think about your cost and your effect. Avoidance, bipedical fixation. Think about cement augmentable screws. Thank you. And because the pull-out's better. Avoid unilateral pedicle screws. We showed that you get a non-union. And these are the summary conclusions, which my time is up, so I'll leave that for you to look at. It's a summary of what I've discussed.